Well, good morning. That was a dramatic opening, and it's a kind of an homage to my days as a young child when when this program came out in the U.S. in 1963. I was in first grade, maybe second grade, and I used to come home after school and sit with my friend and hold hands and watch it because it was, to me, a very scary program at the time, especially that opening was scary. But if you ever have lots of time, you can find episodes of The Outer Limits and watch them. It's kind of fun. It's sort of like aliens and cool stuff, and it was neat. But anyway, good morning. It's Dr. Nick Tullo from New Jersey and from ECG Academy with my Saturday morning live stream. I'm really glad you're able to join us. I see we have the usual crew here. Welcome, welcome. And at the hospital, do they call me? Well, they call me Dr. Tullo at the hospital. Dr. Nick was the thing I came up with when I started ECG Academy. But now, of course, with these live streams, everybody knows who I am, and they can Google me. Hey, Michelle, it's your first one. Congratulations. Yay. Richard, hello from London, all the way there. It must be in the evening. Huh? Anyway, we have an interesting live stream today. I wanted to share with you a couple of arrhythmias that I picked up and deal with first what they are, and then present three different patients who have three completely different histories and how you might treat them a little bit differently depending upon what their history and their underlying heart disease is. Kareem from Kansas, good morning. Good morning to everybody. Brian and Chris and Jaswin. It's so great for you guys to be here, and I'm like tickled that this is such a catching on, isn't it? So if you really like this content, remember, you can subscribe with the link below in the description and subscribe to my YouTube channel and let your friends know, let them, give them the word that we're trying to do more clinical talks and kind of keep it informal. This isn't sort of a stuffy panel of doctors talking about, well, I was the QR restoration. So anyway, let me switch over. So, hey, there we are. We're going to talk about three different patients and two different arrhythmias. So let's get to the arrhythmia first. I'm going to bring this up here and show you. Now, let's say you're a telemetry nurse or a tech, and you see this sort of like at 3 o'clock in the morning. What do you do with this arrhythmia? Of course, what I try to get you to not do is label this arrhythmia. Oops, hold on a second. Let me get my pen tool here so I can draw on it. And see, I should have set this up a little better. So what I don't want you to do is label it as a WCT, wide complex tachycardia. As you see, whoever did this recording didn't want to put their nickel down. And that's a little bit of a problem in my book because it really kind of makes me think that you need to have a better feeling for how to diagnose a wide complex tachycardia. And what I always tell people is look in front of the first beat and see how it started. So you can see this first beat on the tracing is a normal sinus beat with a P wave and a QRS that looks relatively narrow, about 110 milliseconds or so. And Wyatt says it looks like atrial tachycardia with aberrancy. Good morning, Ahmad. Well, I would agree because this 12 lead is sort of like generated by the monitor, so it's not a true 12 lead. But if you look at this first wide QRS beat, it seems to have a P wave in front of it. So, and it's a premature P wave. It comes early compared to the other one. And when you look at this ST segment, you can see another P wave here that presumably gives rise to the second QRS. And as you look across at this tracing, you can see a P wave that appears to precede every single beat. And in fact, here, as the tachycardia slows down, the P waves emerge and the tail end of the T wave. And here you have a clear conducted beat, although it seems to be wide and bizarre compared with the underlying beat. Now, it turns out this patient also had a problem with AV conduction. And so this P wave does block, but that's sort of like less important as understanding and recognizing the fact that this arrhythmia originated in the atrium. And then at the end of the strip, we can see that conduction goes back to normal once the His bundle and Purkinje system have a chance to conduct normally. So if you were to see this at 3 o'clock in the morning as a nurse or a telemetry tech, I mean, how many people would call the doctor at 3 o'clock in the morning? I know that some hospitals have particular policies that you need to follow. I suppose if the policy is what it is, I get that. But if I was the physician, if I was the cardiologist or even the internist who got called for this is obviously an atrial arrhythmia. It's not terribly fast. The patient presumably was asymptomatic, and I would just post this on the chart. I would not label it wide complex tachycardia. I would certainly label it as atrial, an SVT with aberrancy, atrial tach with aberrant conduction. So aberrancy, Michelle, is when the interventricular conduction system, the bundle branches, are not conducting normally. So the signal has to go down one branch and then sort of make its way back around the other way. So the QRS takes longer to inscribe. You have a wide QRS, and it just is not normal interventricular conduction. So that's pretty basic concept. And if you're not, see, the thing about ECG Academy, if any of you have ever gone on there and watched my videos, is I teach the physiology. Why does aberrant conduction occur? And how can you recognize it? And so it's the physiologic approach, because after all, I'm an electrophysiologist, right? So I deal in this world, and I want people to understand arrhythmias the way I do. From a physiologic standpoint, what's the AV node doing at this moment under these circumstances? What's the conduction system doing? So that's the only way to really truly understand this. It's not an abnormal pathway. The normal pathways are the bundle branches, the conduction system, but one of them is misbehaving, and that's why it's taking longer to get around the QRS. Okay, so atrial tach with aberrant conduction. So then, let's say the same patient later on does this, and this is, let me show you my screen. So here's a different tachycardia. Now you have, this actually came from a Holter, but the point is that you have pretty normal conduction up here, PQRST, and then you have another wide complex run here. And it's wide and bizarre, and it's not terribly fast. It starts out kind of slow, actually, at a rate of around 100 or so beats per minute, 120. And it gets up to maybe 140 before it breaks, and then you're back in a normal sinus rhythm again. So the rule is, if it's SVT with Wyatt is asking if it's SVT with aberrancy, do you still treat it with adenosine? But it was only non-sustained. You wouldn't treat that because it's not by itself, okay? If you have someone that's in sustained SVT, depends on what it is. It may or may not respond to adenosine. But with non-sustained, you basically see this on the monitor. The patient had no symptoms at the time, and documenting it as atrial tach with aberrancy is far better. Jaspinder, good morning, is far better than labeling it wide complex tachycardia. But now this one, look at the first beat of this tachycardia, and you can see it's not terribly fast. It's not premature the way the last beat was. And when you look in front of that first QRS complex, do we see a P wave? Did it start with a PAC? Is the atrium driving the signal? And the answer is no. I mean, if you look at this T wave and this segment, it looks exactly the same as this one. So this first beat did not appear to come from the atrium. and it's wide and bizarre, and we'd call it ventricular, and the second beat as well. But what's the hallmark of ventricular tachycardia? How do you know for sure that it's VTach? Well, the one thing that ultimately is the best way to recognize and to diagnose VT is to find, anybody? AV dissociation. Satip, you got it. It's AV dissociation. And where do we see this? Well, in the second strip down here, we can see AV dissociation if we look at the interval between QRS complexes and compare one beat to the next. Okay, remember that ST segments and T waves change gradually over time. The change in voltage is very slow, whereas P waves tend to be much faster, more high frequency components to P waves. So this right here is a P wave that's superimposed on the T wave, and then you see another one over here in a different place. And so we can see that the P waves, here's another one here, because that is not part of the QRS complex, it's absent in this beat. So the P waves are kind of marching through at a much slower rate than the QRS complexes, and that tells you that it's ventricular tachycardia. I mean, this is pretty much unmistakable. To call this a wide complex tachycardia, or because it's irregular, a lot of people would hedge and maybe consider it AFib with aberrancy. No, no, no. You have to put your nickel down. You have to be able to recognize these little fine details, these little subtle clues that tell you exactly where it's coming from. And this is non-sustained VT, pure and simple. So now, what do you do with it? I mean, at 3 o'clock in the morning, do you call the attending? Well, I hope not, because, I mean, if the patient's asymptomatic, it's a run of non-sustained VT, which is a very common thing. A large number of people with and without heart disease will have runs of non-sustained VT, and unless you're having recurrent episodes multiple times an hour, then you might want to think about checking electrolytes or making sure that the patient is okay. But for just this one run, I don't think it merits waking the attending up in the middle of the night. We don't see the last complex in the first line above. Uh-oh. Let me just see something here. Oh, I see. You know why? Because my... okay, I'm going to fix that because I'm going to put the screen capture at the top, and that should... Well, let's see if that worked or not. Well, all right. What I can do is just drag my picture out of the way. You don't need to see me, right? Okay. So now I think you should be able to see that first complex. All right, better? I'll just have to move like this. Yes, okay. It's it's not perfect, and I can't see exactly what you're seeing, but there's that first complex over here. Is got that P wave superimposed on the beginning part of the QRS complex, and that you don't see it in all the other beats, so you know it's not part of the QRS, it's the P wave, okay? Okay. Is it normal variant for VT to wind up in rate, to have a warm-up phenomenon? It's not normal, but when you have to consider what the mechanism of the VT is. Most VT, I would say, non-sustained VT, may very well arise from a focus, a small area, a region that's behaving abnormally, and so that focus starts to fire and causes these ventricular beats, but these automatic foci will sometimes warm up and then they'll cool down and they may become irregular. The only VT that's really dangerous is the re-entry kind, that gets stuck going round and round and round because of an area of slow conduction, usually related to some myocardial scar, okay, or abnormal conduction within the left ventricle that causes it. And they tend to be very regular, they tend to be a lot faster, and obviously they can become sustained, and those are the things that really result in cardiac arrest and sudden death and all of that. So just having a run of non-sustained VT does not necessarily predict that the patient's going to, have a cardiac arrest or code 99 tomorrow. But that's where the history becomes really important, okay? That's why that's why we're talking about this, because I'm going to present 3 different patients to you. So think of a normal patient, say a 35-year-old who comes in with appendicitis, and they've no cardiac history. They're not on any medications. They're just getting some antibiotics, some cephalosporin or something, and they're in bed and everything is fine. And then in the middle of the night, they have one of these arrhythmias. Okay, let's start with that. I mean, what if you had someone with that atrial tachycardia with aberrant conduction? Ooh, I mean, is this something that you would be concerned about? Well, I think what it merits is a discussion with the patient. I go to the patient and say, hey, when you're home, do you ever feel your heart sort of feel like it's racing? So half the time they'll just say, no. But sometimes they will say, now and then I'll feel a little flutter. It lasts for a couple seconds or something like that. And then I'm fine. And it's been going on for years, and I don't pay much attention to it. And in that case, I wouldn't do anything. I mean, non-sustained atrial tachycardia has no impact on someone's prognosis. It may cause minor symptoms, but it generally won't get worse. At least in most patients, it won't become sustained, or it does not predict atrial fibrillation or strokes or anything like that. So atrial tachycardia, or PAT we used to call it, it really depends on the symptoms. So we really treat the symptoms. How bad are the symptoms, and how long does it last? What's the worst it ever? You ask them, what's the longest you ever had? Good morning, Ashke. What's the longest it ever lasted? If they say, less than a minute, that's fine. If you tell you it went on for hours and hours, then it may be something to explore. As an outpatient, you might want to get a sense of how often it happens, whether you could catch it on a monitor, look at the patient's history, make sure they have a normal echocardiogram, that they don't have some serious valvular problems that you were unaware of, make sure their blood pressure is well controlled, and so on. But it's mostly for symptomatic treatment. Now, what about that non-sustained VT? What if you were to see non-sustained ventricular tachycardia in a normal, healthy 35-year-old patient? Would it be something you'd be concerned about? Most of the time, no, because having ventricular tachycardia does not really affect prognosis in someone with a normal heart. So what do you want to do? You want to make sure they have a normal heart. Okay, so you want to maybe get an echocardiogram, just verify their ejection fraction is normal, that they don't have any sort of subclinical cardiomyopathy. You might want to do a Holter, see if it's happening all the time. Because some people can have an automatic focus that's firing all the time, and they may have thousands and thousands of PVCs all day long, and runs and this and that. So you want to kind of look at the big picture. But assuming the patient is not symptomatic, and assuming that they don't have 15 or 20% ectopy on their Holter, and assuming their echo is fairly normal, we don't treat that. We don't start beta blockers. We don't put people on medications for asymptomatic non-sustained VT. Space Fed from Malaysia. Hey, it's my new recording studio now, huh? Right? So this is months I've been planning this thing. We dug out the basement. We put this new room. It's got sound paneling and cool lighting and everything else. So this is my new home for Chalk Talks on ECG Academy, and of course these Saturday morning live streams. So thanks for noticing. Okay, so let's talk about the second patient. Let's say you have someone who's 55 years old, and they have diabetes, and they have hypertension, and their last ejection fraction was about 40%. And they have a sort of a segmental wall motion abnormality that they picked up along the way, and let's say they've had a stent in the past. So again, the atrial tachycardia with aberrant conduction in a patient who has underlying heart disease is still not going to affect their prognosis significantly. They have plenty of reasons to have atrial arrhythmias, don't they? I mean, if their ejection fraction is reduced and they have a history of hypertension, diabetes, they can have all sorts of endocardial dysfunction. And so those are people who may be set up for atrial fibrillation in the future, right? So that's somebody that you might want to monitor a little bit more closely. You might want to set them up for an event monitor, maybe have them wear a patch for 2 weeks just to see how much arrhythmia they have and whether they have atrial fibrillation as well as that atrial tachycardia. Sadeep says, is 20% burden the kind of cutoff for starting antiarrhythmics for asymptomatic non-sustained VT? Well, that's a good question, and it is controversial. We know that people who have very, very frequent high-grade ventricular ectopy, 20%, 30%, many of them will go on to develop a kind of a PVC-induced or rate-related cardiomyopathy. But in the absence of symptoms, and assuming the left ventricular function is normal, there's still no evidence to show that treating the arrhythmia with beta blockers or calcium blockers does anything. Now, it's different if someone has left ventricular dysfunction, and it may be related to the PVCs, and in that case, using an antiarrhythmic drug to suppress the PVCs may be helpful, but in extreme cases, those patients might benefit from a catheter ablation of the arrhythmogenic focus, especially if you see their left ventricular function deteriorating. Okay, so now what about the non-sustained ventricular tachycardia in the patient who has an ejection fraction of 40% and they have hypertension, diabetes, they have a stent, they have coronary disease? Would that concern you? 40% ejection fraction, non-sustained ventricular tachycardia. Well, there again, it's a little controversial. There's no definite guidelines in that case. Certainly, let's say the patient had a history of syncope, like 3 months ago. They were standing on line at the 7-Eleven and they suddenly found themselves on the floor. That would definitely be a warning sign that you may be dealing with someone who has a reentry circuit, who may have sustained VT, who may have passed out because of ventricular tachycardia. And those are patients that you would recommend electrophysiologic evaluation and perhaps an EP study to see if they have inducible sustained VT. If you were at my live stream from, I think, last week, there was a patient who had this Mr. E tachycardia, wide complex tachycardia that was treated for VT, and then we brought him to the lab and we were able to induce sustained ventricular tachycardia. If you haven't watched that live stream, go back to my channel on ECG Doc on YouTube and you'll be able to watch it because it's a cool discussion and I show electrophysiology tracings and so forth. But so if you have a patient with a history of severe symptoms like syncope and they have a low ejection fraction of, like, say, 40% with segmental wall motion abnormalities, and they have a run of non-sustained VT, that's a bad combination. That's a triple threat. That's someone that you need to be concerned that they could potentially have a reentry circuit, and that should be pursued. EP testing is quite indicated in that sense. Now, that kind of brings me to the third patient. So the third patient now, let's say, is 75 years old, and they have a history of heart failure, and they have an ejection fraction of 30%. And now, if you see atrial tachycardia with aberrant conduction, what are you going to do? It may not be any different than the other patients where you're mainly concerned with symptoms, but you're also concerned that it may be a marker for other arrhythmias like atrial fibrillation, which could potentially raise the specter of a stroke. You don't want them to have a stroke, right? So that's someone that you would monitor more carefully. You want to make sure that their hypertension is well controlled. You want to make sure they're on an ACE inhibitor. You want to make sure that they are on a beta blocker like carvedilol. But when you have someone with an ejection fraction of 30%, those people are at risk of sudden death regardless, aren't they? I mean, those are patients, I mean, when you have an ejection fraction of 30% or below, those are people who may qualify for an implantable cardioverter defibrillator for primary prevention of sudden cardiac death. So especially that guy, if this patient with the EF of 30% had a run of non-sustained ventricular tachycardia, you know, you would really strongly recommend that they consider having an implantable defibrillator put in, because they may be at risk of sudden death. You know, what risk? It kind of depends, but some people have reported annual risks of anywhere between 5 and 10%, depending upon the ejection fraction. So if it's 30%, the risk may be 5% that they're going to have a cardiac arrest, 5% annual risk, and those are patients who definitely qualify, at least in the States, to have an implantable defibrillator. In a way, once you cross over that 30% ejection fraction, if you have a segmental wall motion abnormality, especially ischemic cardiomyopathy, you kind of bought an ICD for yourself, regardless of whether it's atrial or ventricular. I guess the only caveat to that is, let's say that it's a non-ischemic cardiomyopathy and the ejection fraction is 30%, but they're on minimal medications. Let's say they're coming to you brand new and they have no history of heart failure, there's no history of myocardial infarction, you do a stress test and they have no evidence of ischemia. Those are patients that if you aggressively treat them with afterload reduction, carvedilol, ACE inhibitors, ARBs, diuretics, you might be able to get their ejection fraction up above 35%. And in that case, perhaps their risk of sudden death will drop dramatically. And some of the studies have suggested that if you can get their ejection fraction up over 35%, then they tend to have the same long-term risk of sudden death as people who were started out at 35% or above. So the Danish trial raised controversy for ICDs and non-ischemic heart failure. Yes, it did. And that's why I'm suggesting that if you have non-ischemic cardiomyopathy, you want to aggressively treat those people with the medications as I suggested, because if you can improve their ejection fraction, their prognosis tends to improve. And I think even though the SCUD-HEF trial suggested benefit in patients with non-ischemic cardiomyopathy, I think when you tease out the data, the people between 30 and 35% ejection fractions really did not, as a group, benefit from ICD therapy. So you do have to consider that, you know, perhaps aggressively treating them with medical therapy might be the way to go with that. So CRT can be used for what? Okay, the only patient, in my opinion, and what most of the data suggest, is that the only time the cardiac resynchronization therapy is effective in the majority of patients is when you have a left bundle branch block. Okay, so don't assume that CRT benefits ejection fraction in everybody. It's known as cardiac resynchronization therapy. So you have to have desynchrony in order for those devices to really have a benefit. And even if you have the ideal patient with a left bundle branch block and left ventricular desynchrony, there's still about 30% of patients don't respond. They have no improvement in their functional class, so there's no benefit to CRT. So be very careful about recommending CRT for everybody with heart failure. It's really designed to treat desynchrony, and if you don't have desynchrony, if you don't have a left bundle branch block, it's probably not going to help. And certainly then, unless you have left ventricular desynchrony with a left bundle branch block, the ejection fraction is not going to get better. So most of the time, if you recommend an implantable defibrillator for primary prevention, it's not to treat heart failure. It's really to prevent sudden death. Okay, so we've kind of gone through the gamut now. We've got 3 patients, sort of like healthy, some risk, intermediate risk, and then high risk. And we've talked about atrial arrhythmias versus ventricular arrhythmias, which ones we treat. For the most part, you have to talk to the patient, find out what their symptoms are, make sure that you understand the degree of their heart failure, or their underlying cardiac disease, because that's going to definitely affect how you treat those patients. So anyway, I hope this was fun for you. It's a half hour now. I know Outer Limits was an hour. Sit back for the next hour. Well, I should say, I should redo that voiceover and talk about relax and for 30 minutes, and we'll go down this avenue of arrhythmias. But I'm glad you were able to join me. I really appreciate everybody who's a part of this. And remember, if you enjoy this content, make sure you subscribe, pass it on, let your friends know to subscribe to ECG Doc, which is my YouTube channel. And obviously, if you feel that you want to understand ECGs, if you want a great course, then ECG Academy is my certificate course that I provide. And until next week, I bid you adieu. I hope you have a terrific week, and thanks for joining me, and have a great time, and we'll see you next week. All right. Bye.